Uh, Good evening, and it is a great honor to be with you today in this kidney transplant, continuous medical education, and offering new possibilities. This important session of the Egyptian Society of Nephrology and Transplantation, also sponsored by Sandoz company, which is a Novartis division, is dealing with very important aspects that we'll cover with 4 eminent speakers. Dilemma of managing antibody-mediated rejection by Professor Maya Hasaballah, followed by how to define immunological risk in kidney transplantation by Professor Christophe Legendre from Paris, followed by hot issues in kidney transplantation research by Professor Hussein Shaisha, and at the end, improving outcomes in kidney transplantation by Professor Magdi Sharqawi. I hope to give you some housekeeping messages. The whole sessions will be finished around 10 p.m. and ask attendees send the question to the different speakers on the spot, because we will make 2 stops for the question, the first after the second talk and the second one after the last talk. And at the end of the day, attendees could claim their certificate for attendance. The first speaker in this important symposium will be Professor Maya Hasaballah, Emeritus Professor of Internal Medicine and Nephrology and President-elect of the Egyptian Society of Nephrology and Transplantation. She will be speaking about the dilemma of managing antibody-mediated rejection. Professor Maya, please.
Well, thank you very much, Dr. Hani, for the introduction, and I'm really glad to be here in this important meeting and this very important subject, the dilemma of managing antibody-mediated rejection. So the agenda will include the magnitude of the problem, pathophysiology of AMR, therapeutic approaches to treatment of AMR, treatment limitations, expert consensus from the TTS working group, and prevention. So AMR is estimated to occur in 3 to 10% of low-risk transplant recipients and up to 50% among recipients of HLA-incompatible grafts, and it represents 20 to 30% of episodes of acute rejection. And this is really bad news, because if it's clinically silent, it is associated with twice as much the risk of graft loss. And if associated with graft survival, the risk is 6 times. And antibody-mediated rejection portends recurrent AMR and ultimately chronic AMR and transplant glomerulopathy. HLA antibodies occur in 25% of transplant recipients and 30% of patients on the wait list, and successful management of HLA sensitization and AMR continues to represent an important unmet need in solid organ transplantation. So actually, this antibody-mediated rejection is formed by antibodies that are donor-specific HLA molecules or ABO antigens or endothelial cell antigens, and they could be either formed, such as occurs in highly sensitized patients due to previous transplantation, blood transfusions, or repeated pregnancies, or they could occur de novo as in patients, and this usually occurs in the context of under-immunosuppression and non-adherence. But the problem is that you can have a memory response where you could have this form of memory cells could be present, but no production of antibodies, or antibodies are not detected. This is a big problem and a big challenge. Now, the revised Banff classification 2018 divided AMR into active AMR, chronic active AMR, and CD4 staining without evidence of rejection. So C4D positivity has been reported in the absence of other evidence of graft injury, and C4D staining is now considered as an alternative for DSA criterion, as well as gene transcripts and classifiers. But thorough DSA testing, including testing for non-HLA antibodies, if the antibody testing is negative, is strongly advised, and of course, expression of endothelium-associated transcripts. We have AMR, more molecular sets proposed, but no recommendations yet. So what happens is that the T cell gets stimulated by antigen-presenting cells. With antigen presentation, that this is going to activate the naive B cells to proliferate and differentiate into memory B cells and plasma cells secreting antibodies. And when the antibodies interact or bind to the endothelium, they can undergo direct signaling, or they can induce Fc gamma receptor activation of natural killer cells and macrophages, or they can fix complement through the classical complement pathway. So actually, they do not behave similarly, and the greater risks for rejection and worse outcomes occurs with C1q binding DSAs or class 2 DSAs and de novo DSAs. So that's what happens. They can either cause direct injury or indirect injury to complement activation or inflammatory cells. And if you have a cross-section of the microvascular vasculature, you will see intracapillary presence of activated cells, including CD4, monocytes, macrophages, natural killer cells, and so on and so forth. And how are you going to treat all that? We're actually treatment depends on a combination of drugs that target different steps in the pathogenetic pathway, including polysteroids, thymoglobulin, belatacept early on, and you have rituximab for B cells, bortezomib for plasma cells, and you have plasmapheresis for removal of antibodies, and you have eculizumab for the complement inhibition of late C5, and you have IVIG, which is pluripotent. But actually, the more drugs are also coming, like and other CD20 monoclonal antibodies that are more potent, like the carfilzomib, which is also more potent than bortezomib, which is irreversible and less toxicity. We also have the CD38 monoclonal antibodies that may target other cells, like the natural killer cells and plasma cells and regulatory T cells. We also have the costimulatory monoclonal blockers, like anti-interleukin 6 and interleukin 6 receptor monoclonal antibodies, the tocilizumab and clazakizumab. And we have also the anti-B lymphocyte stimulator, belimumab. We also have the C1 inhibitor, the IDEs. We have the IDEs, which target the immunoglobulins themselves, and we have the C1 inhibitors targeting the early complement components rather than early complement activation, rather than the eculizumab, which acts later step. So having all these antibodies, all these drugs to be used, actually what we have now is that we have no FDA-approved treatment for desensitization, and the current treatment for antibody-mediated rejection stems from low-quality data that are obtained from a small number of controlled trials. And the KDIGO guidelines, they remain unrevised since 2009, and they're suggesting the use of any of the plasma exchange, IVIGs, anti-CD20, lymphocyte-depleting antibodies with or without corticosteroids. And the reason for that is that the previous controlled trials of treatment of AMR have been heterogeneous, underpowered, and of low quality because of heterogeneity in defining AMR, inclusion of acute and chronic AMR, retrospective studies, small number of patients, different follow-up periods, and different timelines. Now, this is a very interesting meta-analysis that was published in 2018. And out of more than 14,000 records, 22 records were included in the study, out of which 10 were randomized controlled trials, and 9 of them were retrospective, and 11 were non-randomized controlled trials, and 8 of them were on acute AMR, 1 was on chronic AMR, and 6 were mixed, and 6 did not report. The follow-up period varied from 1 month to 7 years, but the majority was at least 6 months. And looking at the acute antibody-mediated rejection and antibody removal, 5 randomized controlled trials comparing antibody removal by plasmapheresis or immune absorption, and they showed that longer follow-up periods, 2 to 5 years, showed a trend towards a benefit for antibody removal, but there have been no controlled trials assessing the frequency and volume of plasma exchanged, the composition of the exchanged fluid. About the combination of antibody removal with IVIG, we have 2 retrospective studies, and with showing the graft survival improved after 7 years in the intervention arm in only 1 study, where there was no effect in the other study. So despite the evidence of uncertainty, plasmapheresis and IVIG are still considered the standard of care for acute AMR. Now, what about rituximab? We have 4 studies of rituximab compared to standard of care. In the 2 randomized controlled trials, there was no benefit of rituximab, and there was benefit in retrospective studies. So as such, it has little or no difference to early graft survival. And this is the Retox era, which is a prospective study that divided patients after receiving the standard of care into those that received rituximab and those that received placebo. And if you look at the patients in the graft survival, there was no difference between the placebo arm and the rituximab arm. And well, this gives more credit to the standard of care. But actually, there was a more reduction in MFI to less than 2,000 in the rituximab arm in 1 year as compared to placebo. Well, rituximab was tried in a single-center study for induction in using 1 dose, and it did show a significant reduction in allograft rejection, but only in high-risk patients. Now, what about bortezomib? We have 4 studies compared to rituximab. Randomized control study, there was no difference in 3 years. Well, actually, we have 2 studies, the BORTIJECT trial, where bortezomib had no effect on outcomes over 2 years of follow-up, and Moreno Gonzalez reported that 32 doses of bortezomib were not well tolerated, with only a modest impact on anti-HLA antibodies, and as such, the role of bortezomib is questionable. It may be more effective when combined with other drugs. Now, C1 inhibitors, complement inhibitors, we have 2 studies, and no graft failure in either group at day 20, and less transplant glomerulopathy at 6 months in the C1 inhibitor group. So C1q may be promising rescue therapy in acute antibody-mediated rejection. It was given to those who were not responsive to the standard of care. Actually, eculizumab was not mentioned in this study, but in the year 2019, there were a number of studies indicating that it could be protective, and it can also be used for treatment of early active antibody-mediated rejection. However, low treatment incidence of chronic antibody-mediated rejection and allograft survival was comparable to the historical controls still. Now let's move to the chronic AMR and hear about the antibody removal combination with IVIG. We have no controlled trials. If you look at the quality of studies, you will find that most of them are very low or low qualities. And for eculizumab, we have 1 study, and it showed that there was no difference in actuarial graft survival after 1 year of follow-up. Well, actually, we don't have a drug that proved to be effective in chronic AMR, and maybe because of irreversible tissue damage that occurred in the setting of severely compromised graft functions. We have some studies. This is a retrospective study over 2 years on 62 patients, showing that there was the rituximab, plasma exchange, and immunoglobulins are ineffective treatment of chronic AMR, as also other studies. This is a prospective study showing the same thing. So what we do for chronic AMR is that we escalate immunosuppression, like using steroids, if a steroid-free regimen is used, or change cyclosporine to tacrolimus, or increase the dose of tacrolimus, and so on. But the good news is that interleukin 6 receptor inhibitors has been used in this study, and where patients were divided into those who received a standard of care and other group that failed standard of care and were given interleukin 6 receptor inhibitors and antagonists. And here you can see there was an improvement in the breast, and the patients survived 80% and 91% as compared to the standard of care. And because of this encouraging results, there have been studies going on to try lebrikizumab, which is an interleukin 6 antibody, and to find out its effect in preventing allograft loss due to chronic antibody-mediated rejection. And actually, there are other trials, many studies are going on, including bortezomib as combined regimens together with the lebrikizumab, and we have also the double filtration plasmapheresis, which did not only remove the antibodies but also other molecules, and even corticotropin and camel cells, stem cells. All these trials are going on. We also have the imlifidase, and this is, of course, it is not used for treating of AMR, but it has been used to allow transplantation of the highly immunized patients, where it breaks down the immunoglobulin in the lower hinge regions, and it did result in reduction of HLA antibodies within 6 hours after treatment, and the C1q HLA antibodies within an hour after treatment. And it allowed the transplantation of 24 of 25 patients who were highly sensitized. But the problem is that you have a rebound which occurs within 7 to 10 to 14 days, and it itself has antibodies against it, so you cannot use it multiple times. It will need an adjunctive therapy for that. And this brings us to the drug-related constraints that we have for the IDEs. Of course, the antibody formation and the rebound, and it also inactivates therapeutic antibodies, and is a big problem. And we have the proteasome inhibitors. They appear to have class-specific limitations, such as the development of resistance and humoral compensation induced by plasma cell depletion. The distal and proximal complement inhibitors, we know that not all antibody-mediated injury occurs through the complement activation, and Fc receptor-mediated injury also plays an important role in AMR. And plasma exchange IgG is removed only from the vascular space and thus must re-equilibrate with the interstitium before further antibody removal is optimal, and this process takes about 48 hours. Now we need to have a consensus on the treatment of antibody-mediated rejection, and this comes from experts from the Transplantation Society Working Group, and this was presented in the TTS just last month or a few weeks ago, and they did give their consensus on early acute antibody-mediated rejection due to pre-existing DSAs, and late, more than 30 days of antibody-mediated rejection, which could be due to pre-existing DSA or de novo DSA, and each of them can be either active AMR or chronic active AMR. So the recommendations or the consensus they gave was that for the early active antibody-mediated rejection is to use the standard of care, plasmapheresis, IVIG, and the plasma exchange. Well, for adjunctive therapy, actually, the trials were all underpowered, but since this is a high instance, there is a high instance of graft loss, so you can treat with adjunctive therapy, including complement inhibitors and rituximab or splenectomy, depending on the expertise. And for the late active antibody-mediated rejection with pre-existing DSA, if it is acute, if it is active only, so you use primary treatment, again, the standard of care, and you can have adjunctive therapy with rituximab. But if it is a chronic active AMR, then you only optimize the medical management. We have insufficient data to support rituximab or IVIG, but actually they are still used. What about the late active antibody-mediated rejection with de novo DSA? Here, the primary treatment is to address the medication non-adherence and optimize immunosuppressive therapy. And rituximab can be used as an adjunctive therapy. Chronic active, maybe their IVIG is an adjunctive, but treat or not treat, this is the point of no return, and maybe could be of great help in the future. The best treatment of AMR actually is prevention, and HLA matchmaker software for hypersensitized patients will allow minimization or avoidance of the most immunogenic FLIS mismatches and will allow for acceptable HLA mismatches, and the national period exchange programs in cases of positive cross matches with the living donor, and desensitization because for patients with cross match complement dependent cytotoxicity positive, because after all it does have a survival benefit with kidney transplant patients, and it shows a better outcome when compared over 8 years when compared to those that are still on the waiting list. Again, careful assessment of adherence and routine post-transplant DSA monitoring, and adoption of protocol biopsies in the first 3 months after transplantation for high-risk patients, and proper selection of patients before minimization practice. The challenges we have is the absence of DSA does not imply the lack of memory B cells and the potential for an anamnestic response, and treatment aiming to prevent plasma cell generation and subsequent DSA production may not stop the generation of memory B cells. And in some circumstances, the histologic features suggestive of AMR are present, but anti-HLA antibodies is not detected. But this has been revised by the BANF criteria. And further complicating the diagnosis and management of AMR are various clinical phenotypes, where it can present with abrupt allograft dysfunction early post-transplant, but can also have an insidious or subclinical onset presenting later on. So precise definition of immunological HLA mismatches may significantly contribute to alloimmune risk stratification to accurately predict the risk of de novo DSA formation, and the ability to quantify donor-specific memory B cells may aid in risk stratification and treatment of pre-sensitized recipients susceptible for the active AMR, early post-transplant, and definitely we need prognostic scores to guide the use of drugs, and we need also new agents and controlled clinical trials urgently. And thank you very much for your attention.
Thank you very, very much, Professor May. This was very up-to-date trial to solve the dilemma of management, but also still, I think many, as you just mentioned, research is ongoing, and maybe in the next few months we will get more drugs approved. It is my great honor to present my dear colleague, Professor Hussein Shaisha, professor of nephrology in Mansoura University, and chair of the Egyptian Society of Nephrology and Transplantation Continuous Medical Education, with huge webinars done in the last 9 months. He will speak today about hot issue in kidney transplantation research. Professor Hussein, please.
Okay. Good evening. It's my pleasure and honor to be with this very valuable gathering. I would like to thank Professor Hani Hafiz for his kind and sincere introduction. So I'm going to highlight the most updated publication in the field of transplantation. Everything is going on and there is explosion of research. This is why it is impossible to harvest everything. So this was my presentation since 2 weeks, and today I'm going to present new data. So these are the outline of my presentation, and I'm going to start with immune suppression and tissue typing. So regarding tacrolimus is the backbone of maintenance immune suppressive drugs. Here, I would like to present the interaction between tacrolimus and the tissue typing by the EBLET and the high resolution tissue matching. This is the matchmaker that brings patients into either low, intermediate, or high risk according to the number of EBLET mismatch, and this is the number of patients in each row. So this is the very nice study because, as you see, in comparison to low immunological risk based on EBLET mismatch, the both intermediate and high risk attain a high donor-specific antibodies. And if we look here, this is for intermediate risk, there is increased DSA by 15-fold, and for high risk, more than 20-fold. But if we focus on tacrolimus level, if we keep tacrolimus level within the high therapeutic range, above, even here, above 6 to 7, it will reduce donor-specific antibody. So if we refine tissue typing, this will be a stimulus to refine immune suppression and not to accept low target of tacrolimus to avoid DSA. One of the nightmare of tacrolimus is the high inter-patient variability, and high inter-patient variability is translated into poor graft outcome, either due to rejection or toxicity. I'm not going to discuss this point, but I like to highlight our work in the genetic in collaboration with Greece partner to address cytochrome B3A5 gene and to correlate the gene variants with tacrolimus dose. So this is the number of patients that we have, 76 renal transplant patients, all of them are Egyptian, and we assessed cytochrome B3A5 gene variant and correlated this variance with tacrolimus dose. The method used is PCR restriction fragment length polymorphism, and this is the main result that we have. The majority of our patients, more than 70% of our patients are homozygous non-expressor or slow metabolizer. And less than 1/3 is heterozygous expressor and non-expressor. If we compare the dose at the first time after transplantation and after 1 year, this is the concentration dose ratio. If the patient has slow metabolizing capacity, so you can expect concentration dose is higher than heterozygous expressor, and this is what we have from our data. So it seems that if we know the genotyping of our patients, we may preemptively change the tacrolimus dose. This is our way of thinking now, is to combine both pharmacokinetics and pharmacodynamic in monitoring tacrolimus, because tacrolimus starts its journey through entering the cell, binds to FK binding protein, immunophilin binding protein, and then to make this complex that inhibit calcineurin. And after inhibition calcineurin, the first step in the mechanism of action, this means pharmacodynamic, is the reduction of nuclear factor of activated lymphocyte related gene expression, and then reduction of cytokines and interleukins. So if we measure nuclear factor of activated lymphocyte related gene expression plus drug level, I think this will be the best, because suppose we have a patient with tacrolimus level 3 nanogram per ml. It is low therapeutic window, but if we find nuclear factor of activated lymphocyte is suppressed, no need to increase the dose. This is why we tested this hypothesis in two groups of patients. Group of patients with vivid pneumonias and infections that reflects over suppression to evaluate nuclear factor of activated lymphocyte. And for another group, in another direction, rejector group, to have a look on nuclear factor of activated lymphocyte, and our rationale not to leave pharmacokinetic, but to use combined monitoring, both pharmacokinetic and pharmacodynamic monitoring. Regarding recurrent glomerulonephritis, this is the most recent review article, combine all the results of what was published before this date. It is November this year. As you see, this is the current rate of recurrence for FSGS, IgA, MPGN, and membranous nephropathy. You can find the values is little bit different from what we expect. This is the median time of recurrence. As you see, FSGS may recur so early, even hours after transplantation. This is the median time. This is why we have this variability. And this is a graft loss at 5 years, as you see, the best outcome and the lowest level of graft loss is in the IgA nephropathy. The most important point is the risk factors and the predictors for recurrence. For focal and segmental glomerulosclerosis, younger age, and this is inconsistent, aggressive course of original disease, and the most important, as all of us know, is previous failed transplant because of the recurrence and living-related transplant patients. For IgA, zero mismatch. This means that the better the match, the higher the recurrence. So the zero mismatch is associated with higher recurrence. Crescents, younger age, living-related, and the absence of steroid use at the baseline, and this is inconsistent. MPGN, they are the low complement and preemptive. This is why we prefer to do dialysis for a period of time for these patients. Membranous, here you can find the anti-BLAR is added to the algorithm to predict the recurrence of these patients, plus severity of proteinuria and the living-related transplantation. How to screen? Proteinuria is the earliest clinical marker of recurrence of FSGS, and the IgA proteinuria and creatinine, MPGN complement plus proteinuria and creatinine, and again for membranous, we can use anti-BLAR serial monitoring. There is a very wide and broad kit for biomarkers for each lesion. For example, SOBAR here, and here this is the galactose deficient immunoglobulin A1 and complement pathways and anti-BLAR and thrombospondin in membranous nephropathy. How to treat? In FGS, plasmapheresis with rituximab, IgA corticosteroid, here rituximab, and here rituximab for the recurrence. When we discussed the issue of FSGS with Professor Glassock, while he presented his very nice talk in the NephroAlex, I asked him about the role of circulating factors after transplantation for FSGS. And he paid my attention toward the electron microscope. So he stressed upon electron microscope that Banff 2019 stressed on the EM for any case of glomerulopathy. And he brought the hypothesis EM may precede proteinuria by effacement of food process. So surveillance biopsy may be of value for early prediction, and we may have an action before proteinuria. For onconephrology, I think this is a very hot question. If we have transplant candidate with malignancy, for how long we should wait before transplantation? Is it 2 years, 3 years, 5 years, as we know, or there is a change? Let us look at the risk benefit. Dialysis is not guarantee against malignancy, so there is risk of malignancy in dialysis, but it is less than transplantation. But in dialysis, there is increased risk of cardiovascular disease and mortality. So at the end of the day, the risk is less if we go ahead for transplantation. This is why there is a challenging for the dogma of waiting 2 to 5 year waiting time rule. And I think this consensus expert opinion deliver many messages, very, very practical. For each tumor, there is some advices from the expert. For example, renal cell carcinoma, if we are in T1, we can go ahead for transplantation without waiting. For T1B, if we are in the grade 1 to 2, we can go ahead. But in grade 3 and 4, we can wait for 1 to 2 years. If the patient has metastasis, the patient is not fit for transplantation at all. The same for urinary bladder. We have risk stratification based on the categorization of the tumor and the muscle invasiveness. For example, if there is muscle invasive post-chemotherapy, the patient is not fit for transplantation. The most important is to discuss each tumor, each malignancy with the oncologist, and to put all factors together in a blender. We have the cancer factor, natural evolution of the tumor, immune suppressive factor, patient factor, and organ factors. So we put all these factors together and discuss with the oncologist, and then we may decide on individual basis not to wait or to wait according to the overall risk calculation. A very interesting case. This is a patient with graft failure who resumed dialysis, and he suffered from renal cell carcinoma and metastasis, necessitated the use of immunotherapy, immune checkpoint inhibitors, while the patient is on dialysis. What happened? The patient presents with hematuria, allograft pain, and malaise. And the radiology of the graft shows a swollen graft and tender graft, necessitated graft nephrectomy. Pathology of the graft revealed rejection. So this, to put in mind, if the patient is even has graft failure and on dialysis, to respect the presence of graft. For patients, this is a very practical point. If we have a patient on the transplant list and he had COVID and recovered from COVID, for how long we should wait before proceeding for transplantation? 2 weeks, 3 weeks, 4 weeks, or month? The dogma for general surgery, it is to wait 2 weeks. For after repeating PCR, everything is fine. No PCR is negative, no lung infiltrate, and nothing. The patient recovered for 2 weeks. It's okay to go for surgery. But for transplantation, and because of the use of immune suppressive drug, there is a suggestion from this letter to the editor to wait for weeks. Even when we discuss one of our cases, one of my senior was persistent to wait 3 months. But at the end of the day, we have a consensus to wait for 1 month, so long as everything is perfect and the PCR is repeatedly negative. When we have COVID in transplant patient, we should put the patient under microscope. We should be meticulous, thorough evaluation of the patient because of the relapse that may occur after recovery. And now, and this is a very nice cohort. This is how to predict the severity of the disease and the mortality. So these are lab parameters of cytokine release, including C-reactive protein, interleukin 6, high sensitivity troponin I, D-dimer. If you find the cutoff point exceeding all these values, we can predict the severity of the disease and the mortality in the hospital. Another cohort of patients showing the clinical manifestation, as you see, fever, cough, dyspnea, diarrhea, all these, and the outcome of this cohort is either mortality or respiratory distress syndrome. I'd like to add to the previous biomarkers that I mentioned in the previous study here, lactic dehydrogenase, especially in elderly patients. So if LDH is high at the time of this diagnosis, this predicts worse outcome. The last article I'd like to highlight is this one, and it was published online yesterday in Transplantation Journal, and it addresses the biomarker FOXP3 mRNA profile in the urine. So they measured urinary FOXP3, and as you see, the interesting and exciting point here is to predict the reversibility of T-cell mediated rejection. So if the results are unadjusted or adjusted, fully adjusted, again, the FOXP3 in the urine can predict 3.8, the odds ratio for expecting reversibility of T-cell mediated rejection. And we can put this hypothesis. FOXP3 mRNA level in urine can predict the reversibility of T-cell mediated rejection episode. It is green color. And reversibility of T-cell mediated rejection episode is associated with better graft survival. So the question is, does FOXP3 mRNA level in urine predict graft survival? The answer is no, because reversibility of T-cell mediated rejection as predicted from FOXP3 nullify the effect of FOXP3 level on the graft survival. So I'd like to stop here because of the time limits, and thank you very much for your attention.
It's my great honor and privilege to present my dear brother and colleague, Professor Magdi Sharqawi, Professor of Medicine and Nephrology at Ain Shams University. And Dr. Magdi just finished a very fruitful congress in the last week, dealing with updates in dialysis and in different aspects of nephrology. So thank you very much for this big effort that you did, Dr. Magdi. And today we'll shift gear to transplantation. So he will be speaking about improving outcome in renal transplantation. Professor Magdi Sharqawi.
Thank you very much, Professor Hani, for this kind introduction. It was a great honor to have you with me. The success last week was yours, Professor Hani, from your support, and the Egyptian Society of Nephrology, of course, and Professor Mai as well, and Professor Hussein, of course. Today, I'm going to present about a very important subject in transplantation, how to improve outcome. We all know that transplantation is the best option for patients, even those that have incompatible transplant. And the survival of such patient is very important. And there are many advancements in medication over the years. But again, there is a lot of challenges and threats to the patient. We need to improve the long-term survival as well as to improve, to prevent rejection, as Professor May has presented. So today I'm going to, how can we work this out? First, we have to encourage patients to transplantation, especially young, because the best results are in those that below 20. This is not what is happening. We usually transplant 40s and 50s, but if we transplant children and young patients, the outcome will be much better than waiting for a long time on dialysis. And that's because the cardiovascular outcome are best if the patient is not on dialysis yet, and also the health, the quality of life is much better when the patient is transplanted. And encouraging liver donation is very important, especially from if the patient young, he will have a relative that can donate his kidney. And this is very important. It's important to tell the family that the donation will not affect them much. This study showing that the average time, the average years lost from life of donor is just 0.5 to 1 year in most donors, liver donors. Then we have to change how we select our patient, because most patients, we select patient for transplantation, but patient should know that he is a candidate for transplantation. He should be informed about the possibility of transplantation from his family, from his relative, from a dedicated donor. And also, if we have to encourage cadaveric transplantation to provide donors. As Professor May illustrated very clearly that we have to risk stratify the patients in order to tailor an immune suppressive medication that will prevent acute rejection, because prevention is the most important cause, not treatment. And so this risk predictor can predict the outcome and can tell us how we tailor induction therapy and post-transplant medications. Again, one very important subject is the impact of the R&DQ mismatch and the iplets. As again, Professor May and Professor Hussein illustrated, we have to include them in selection of our patient, especially in liver donation, because they have impact on outcome. This iplet mismatch have a great impact in outcome and in rejection. Then again, we have to address patient compliance. When selecting patient for transplantation, we have to have a psychological assessment for the patient, because he should adhere to treatment, because as we all know, the most important cause of rejection or graft loss is non-adherence. So we have to select patient according to a very strict criteria in adherence. One aspect to improve outcome is to select the proper induction therapy. Nowadays, and starting from the year 2008, almost 82% of kidney transplant patients are receiving induction, because induction will allow us to use minimal dose of immune suppression later on, and we can avoid steroids if we induct the patient. So induction has a very great impact in the outcome of renal transplantation. And this is the OPTN annual data report showing that almost 80% of patients are now receiving T-cell depleting agents, and interleukin-2 receptor are declining or not used. The other like almatizumab and rituximab are minimal. Using low-dose ATG has proven to be as effective as the standard dose of ATG with less side effect and PTLD later on. This is a very, very recent study showing that this is 1,100 patients. This is a retrospective study showing using low-dose rituximab with thymoglobulin induction will allow steroid-free and very good outcome in patients with renal transplantation. Then we come to maintenance immune suppression. Of course, we need to tailor the immune suppressive treatment. As the 80s, when cyclosporin is introduced, the outcome of renal transplantation became much better and the rejection become much less. And nowadays, we have many protocols, including steroid, CNI, emitter, and co-stimulatory pathway. We can postulate that in most patients transplanted worldwide are using tacrolimus. Professor Hussein showed that tacrolimus is very important treatment, especially in those with high risk. So many patients, over 75 patients, are using tacrolimus either twice or once. then prednisolone, almost 70%, and 50%, 55% are in mycophenolate mofetil, and the rest are using other drugs like mycophenolic acid, cyclosporin, sirolimus, and everolimus, and platacept. We have protocols to reduce the complication of long-term transplant complication, especially steroid, because steroid is the most feared from all patients. It induces diabetes, hypertension, dyslipidemia, and we can withdraw this medication if we intend in low-risk patients below 3 months, before 3 months after transplantation, using CNI and MPA as maintenance therapy, and usually you will need induction before deciding on steroid-free protocol. And the best result in steroid-free protocol was when we used tacrolimus and MMF with this protocol. And this is a very recent publication showing that the effect on the graft and the effect of the rejection rate are almost the same with or without tacrolimus, but on the expense of less cardiovascular risk in patients with steroid withdrawal protocol. Also, there are now protocols to CNI minimization and withdrawal. CNI minimization started with the ELITE Symphony study, in which the best outcome was by low-dose tacrolimus, MMF, and steroid, and it showed the lower rate of rejection and the better graft and patient survival. And so we are now using the minimal dose of CNI. Some other protocol is to convert into mTOR, and this requires patients with GFR more than 40 and no proteinuria. However, recently, 3 years ago, the Transform study showed that using everolimus and either tacrolimus or neural calcineurin inhibitor is non-inferior to using MPA and CNI. And the graft survival and the GFR is almost the same, with less CMV and malignancy in the arm using everolimus. And this is another study, the Athena study, a 12 months prospective randomized controlled study, stating the same: everolimus with TAC or cyclosporin in de novo kidney transplant demonstrate comparable efficacy and no difference in proteinuria compared with MPA and TAC. So this is another way to reduce or to prevent CNI, especially in those who are, as mentioned by Dr. Hussein, have a regular or unusual level. Nowadays, this is again the 2018 annual data report of the OPTN, showing that most patients worldwide are using either TAC MMF steroid or TAC MMF alone. 85% of patients transplanted on this protocol. There are other protocols, the co-stimulatory protocol, which is belatacept and other drugs. Belatacept is not present in Egypt, but it works in second signal or co-stimulatory pathway. It has good effect on GFR. It's better GFR than with with calcineurin, and also less hypertriglyceridemia and less diabetes induction, and it's also improved diabetes in those post-renal transplant. Finally, as Professor May presented very elegantly in the first presentation, we have to prevent and to treat rejection. Rejection is the most feared bad outcome in renal transplantation, and in this very nice review article showed that we need to detect rejection as early as possible, and biopsies sometimes fail to show us the instance, the exact pathology, and we can miss acute rejection. So nowadays we might use molecular microscope if it is available, and there is growing evidence that using this technique will diagnose and will help us in preventing or treating this early. Also, again, it can differentiate between rejection and inflammation. And also we might need a biomarker that can diagnose early acute antibody-mediated rejection. And there are many biomarkers in the market or in the research or still in the pipeline. The 3-gene signature urine cell palette, the K-sort, the CXL9 protein. Some of them are now examined, and the donor derived cell-free DNA is also very good marker of early rejection. If you can detect donor-derived cell-free DNA in the serum of the recipient, we can detect or can anticipate antibody rejection. And also, there are some microRNA that may help. We are still waiting for a proper biomarker to diagnose antibody-mediated rejection. Professor May greatly described how we treat antibody rejection, and nowadays we have many therapeutic challenges and many new medication in the pipeline. Some of them work on the CD20 costimulatory pathway, anti-PLIS and anti-interleukin-6, and some work on the natural killer cells like the CD38 anti-molecular antibody, and some work in the immunoglobulin like the IDs, and intravenous immunoglobulin and plasmapheresis, still what we have nowadays. And there are many studies with eculizumab, with IVIG, with bortezomib. Professor May showed us that some of them are very promising. Some of them will be in the guideline soon. Finally, if we can induce tolerance, we will improve the outcome of kidney transplantation. And this is a Mercury Group study showing that using donor-derived CD34 hematopoietic stem cells can induce tolerance. This can induce chimerism and may induce tolerance in kidney transplantation. Another way to induce tolerance is the using of exosomes. And if tolerance is induced, patient and the graft survival will be much improved. So this is my last slide, Mr. Chairman. Improvement aspects are a lot. We have to respect all of them. We have to use them properly. It starts, to my mind, by recruiting the proper patient, community education to select a proper living donor, family member will be better, and patient selection and stratification with the use of proper induction and immunosuppressive therapy, good detection of rejection, and good follow-up. And this will improve the outcome of renal transplantation. And thank you very much for your attention.
Thank you very much, Professor Magdi, for this very elegant presentation. And we will take some questions for the last three talks, please, before we go to our guest speaker of tonight, Professor Legendre. So we have three questions. The first one is for Professor May Hasaballah. They are asking about, is there any difference between plasmapheresis and immunoabsorption in the management of antibody-mediated rejection in the evidence base, or they are the same?
Well, I guess as for evidence-based medicines, they were not compared head-to-head with each other. And for the time being, we can use either of them, depending on the availability and the price and all these sorts of things.
Okay. The second question is for Professor Hussein Shaisha regarding the transplantation of COVID patients. You mentioned that we can start doing the transplantation for a patient who recovered from COVID recently. Is there any specific immunosuppression protocol to be used in such patients who just recovered from COVID, or we use the classic immunosuppression protocol like the symphony in the treatment? Professor Hussein, please.
It is a very smart question because, as I mentioned, the patient may relapse again because of immune suppression. And in dialysis, there is a problem in the PCR because PCR wax and wane on dialysis. This is why we should be more conservative. This is why one of the seniors here insisted on waiting for 3 months. But if we wait for 3 months, we will not go ahead for transplantation. So to be clear, risk stratification is essential, and I think it's better to avoid thymoglobulin induction. It is better to select the immune suppressive drugs and to be cautiously in monitoring the patient. So if we use tacrolimus with steroid and mycophenolate, we use the lowest possible dose of mycophenolate. For example, MMF, 1 gram is enough with tacrolimus, because we should weigh the balance between rejection and the recurrence of COVID-19. And the most important is thorough evaluation. So I am against induction by depleting agents, and to cut short the antiproliferative drugs and make proper surveillance of the patient for any manifestations or symptoms.
Another question for Dr. Hussein. You mentioned some new markers in the urine, FOXP3.
Yes.
Do you think this will be applicable on practical grounds, or it is just a research procedure? Because always we are looking for a urinary biomarker.
Yes, it's very nice to look at the urine because it's non-invasive, and up to this moment, we don't have ideal biomarker in nephrology. We don't have troponin of the heart in the nephrology, either in acute kidney injury, in lupus, in transplantation. Even the SA, there are some controversy about the SA. So for all new biomarkers, we should be suspicious, and we should look at larger studies, because the sample size in this study is a small sample size. But the idea of FOXP3, it is a marker of T regulatory cells. Even if rejection occurs and the T cell is active, we can expect the visibility of T cell mediated rejection, but we want larger studies.
Now it is for some question for Professor Magdi Sharqawi. You mentioned some of the tests that could be used. Some of them are in replacement of the biopsy, like the donor DNA. So do you think that there will be a time that we can depend on this and postpone biopsy, or still biopsy is needed?
Again, a very smart question. I think we will never stop taking biopsies for the patient, because biopsy, according to the biopsy, we can stratify if there is acute rejection or chronic rejection or combined antibody-mediated and cell-mediated drug sensitivity or calcineurin toxicity, IFTA. But when there is a borderline biopsy, when we are confused by biopsy, if there's C4D positive, without evidence, without Banff criteria for acute rejection, like Professor May clearly described, we should use biomarker. And biomarker will help, like, you know, Professor Hani, when C4D was introduced maybe 10 years ago, we were very glad because we have a marker now. But it follows that it is not a must. We can find C4D negative acute antibody rejection. So this will add to diagnosis, replace biopsy up till now. Maybe in the future, with the use of proteomics, we may not need biopsy. But up till now, even in clinical nephrology, biopsy is the cornerstone in diagnosing any abnormality in the kidney transplant.
Again, another question for Professor Maya Hasaballah. What is the best test for detection of donor-specific antibody? Do you need to combine, for example, other marker like the C1q, or it is just the crude DSA to test for detecting the donor-specific antibody?
We have to use Luminex. We have to look at Luminex and maybe C1Q may be of importance in the highly sensitized patients. When you have a sensitized patient, you have to work hard to find these whereabouts in terms of antibodies, but not for routine practice, the C1Q. But otherwise, we have to use the Luminex and to detect antibodies on all patients, on all recipients, potential recipients.
In the regard of chronic active AMR, do you think that the steroid withdrawal or avoidance protocol may increase the risk of this chronic active? I mean, it's better to avoid this steroid withdrawal or avoidance protocol. What's your opinion?
I don't understand about the thinking of steroid withdrawal in a patient with chronic AMR. I think this is a very risky patient, so I don't think the steroid withdrawal is right unless even if the kidney is still there and he is completely back to dialysis, we don't withdraw steroids. We don't withdraw steroids now.
For Dr. Magdi again regarding the cell-free DNA, we have a question that it is rather a trend than absolute value. Is this statement true? I mean, when we do this test, it is the trend, not the value that makes diagnosis.
I'm sorry, Professor Hani, I missed the question. The net was
yeah, he is asking about the cell-free DNA. We should do, for example, 2 times the test and see if it is rising or not, or there is an absolute value for the test.
I think we have, if there is it's very high, we can depend on it, but we need to do it if there is a high titer, yes, increasing titer, yes, we can depend on this in diagnosis.
For Dr. Hussein Shaisha, they are asking what is the best way for cross-match?
So it is a very...
It's a basic question.
Yes, it is a very important question because we have here the CDC cross-match, and we have flow cytometric cross-match, and we have the back safety of Luminex for detecting DSA. For even CDC cross-match, the lab should refine the technique because in the Western and in the highly standardized lab, they have T cross-match, B cross-match, and they make dilution and adding anti-human globulin to increase the sensitivity of CDC because CDC is very specific. We will find the cell lysed, but the problem is in sensitivity. Flow cytometric cross-match is associated with false positive results. This is why we depend on flow cytometric cross-match in high immunological risk patients because its validity is high in this occasion and for patients transplanted for 2nd or 3rd time. So these are the different types of cross-match that we have. For virtual cross-match, we don't use it in living donor, although there are some studies and some centers use it in living, but it is primarily for cadaveric to select the organ allocation.
Thank you. I will take 1 minute to announce the next wave of this kidney transplant continuous medical education, which will take place on the 4th of November. This wave will be welcoming many professors. We will have with us Professor Julio Pascual from Hospital del Mar, Barcelona, Spain, and speaking about underlying diseases and infection in kidney transplantation. We'll have Professor Frank Dorr from the Imperial College, United Kingdom, speaking about thank you very much for your attendance in this very important symposium that was gifted by the presence of 3 eminent Egyptian speakers, Professor May Hasaballah, who gave a wonderful talk about the dilemma of managing antibody-mediated rejection. Professor Hussein Shaisha, who gave the hot issues in kidney transplantation research. And Professor Magdi Shar'awi giving an important talk about improving outcome in kidney transplantation. This actually is the first wave of this kidney transplantation endeavoring new possibilities, sponsored by Sandoz and managed by the Egyptian Society of Nephrology and Transplantation. The second wave will be on the 4th of November, and I advise you all to attend, because we will have 3 eminent speakers from abroad. Professor Christophe Legendre from Necker Hospital in Paris, who was supposed to speak tonight, but due to some technical defects, he will be speaking on the 4th of November, together with Professor Julio Pascual from Barcelona, Spain, giving kidney transplantation infections, and Professor Frank Dorr from the Imperial College of UK, speaking about preemptive transplantations, in addition to 2 professors from Egypt, Tariq Elbaz and Tariq Fayyad. Again, we will have Georgia Jordan, lead of the renal pharmacist in NHS of England. So it will be a very important symposium on the 4th of November. I remind all the attendees they could claim their certificate of attendance tonight, and thank you for your participation, and thanks for the speakers for their brilliant and elegant talks. Thank you very much.
Thank you very much, Professor.